with Josina James. I'm a clinical social worker here with the Step Learning Collaborative and the director for social work. So just to make sure that we're all on the same page about what we're talking about when we say psychosis, I'm sure many of you have ideas, and many of you are probably very familiar with this. What we really mean is this term to describe a cluster of symptoms that negatively impacts accurate perception of reality. And this tends to include symptoms such as hallucinations, delusions, paranoia, disorganized thinking, speech, or behavior, isolation or withdrawal from the social environment and from various activities, and a decline in one's functioning. And this may indicate the onset of schizophrenia or another related psychotic disorder. And psychotic disorders tend to onset in late adolescence or early adulthood. So we're really thinking about those high school, college students here. We estimate in the state of Connecticut that there are about 1,500 new cases of psychosis in the state annually. So some examples of symptoms. We think about auditory hallucinations and visual hallucinations as being some very common ones, and often the ones that are most easily identifiable by a person themselves who's experiencing it, as well as folks who are around an individual who may be starting to experience psychosis. And hallucinations can really run the gamut in terms of severity. It may be something as mild as perhaps somebody perceives the wind to be sounding a little bit like whispering on occasion, all the way up to, full-fledged voices kind of day in, day out, maybe commenting on what somebody is doing or giving them express commands. Similarly with visual hallucinations, it may be fairly mild. Things look a little bit odd or blurry or some shadows in the periphery to perhaps fully formed figures in one's central vision, and sort of the middle of the day, for example. Odd beliefs and sort of relatedly paranoia, these two things can go together in folks. One example might be somebody believes that their mother is not their real mother. There's an impersonator, or perhaps a family or a member or friend is in fact an alien, or that somebody is trying to harm an individual. And it can be very specific. This particular individual is trying to harm me in this particular way, or it can be as sort of vague or diffuse as, I don't know, but it just feels in general like people are trying to hurt me or are out to get me in some way. Grandiose delusions are another common one, and again, this really can run the gamut, from folks believing that they've earned multiple degrees, or owning businesses, are millionaires, have won the lottery, are some sort of godlike figure, for example. Um, Ideas of reference, another common kind of delusion that we see in folks, and that's this idea that some sort of stimuli that is out in the environment we perceive to be meant exclusively for us and only us. So, we all drive down the highway and see the billboards, right? And maybe we get a chuckle out of something that we see. Somebody who is experiencing an idea of reference might see that billboard and think that the message in the billboard is meant exclusively for them and only them. One symptom I want to draw special attention to is sort of this deja vu feeling people might experience of kind of going through things again, or feelings of depersonalization or derealization. Folks who are experiencing psychosis might feel almost out of body. Sometimes they'll even describe it as sort of watching themselves from above in almost kind of a bird's eye view, or that they feel like when they're out in the world, they're really kind of moving through this dreamlike space, and that it's not necessarily
This
reality.
meeting is being recorded.
Um, Disorganized speech is another one that I think can be very readily recognized by folks on the outside who are interacting with somebody who may be experiencing psychosis. And, this can be again as mild as somebody not quite making sense when they're speaking, all the way up to, perhaps these ideas that don't fit together at all, or even something we would call word salad, right? Throwing a bunch of words together in a way that doesn't convey to the person on the receiving end what it is that the individual is trying to speak about. Disorganized behavior, that is another one folks such as, educators or providers might readily be able to pick up on. And we really think about these behaviors that seem to have no particular purpose, are very unusual for somebody, might inadvertently be putting themselves or somebody else at risk, seem really just generally inappropriate. Most folks would agree inappropriate given the context or the environment that the individual is in the moment. um, Pacing, speaking out loud to oneself, right? Those can also be some recognizable signs when folks are having really significant auditory hallucinations, for example, or visual hallucinations. They may be observed to be speaking without anybody else around. That can be an indicator that there's some internal stimuli going on. Pacing sometimes can be a way that folks might try to cope a little bit with some some distressing symptoms. Folks may believe that their food's being poisoned, for example. That can be a common one. They may stop eating. They may not eat foods that are cooked or that they haven't seen to be cooked. They may only want packaged foods. So that can be one indicator to look out for. Um, and then, negative symptoms, which we'll get a little bit more into in a moment, can often look in folks like this real disengagement from the things that they care about. Friends, family, sports, video games. Though with something like video games or technology, we also would wonder if somebody's disengaging from that about maybe some potential paranoia there. So what causes psychosis? Generally speaking, psychosis is caused by a mental illness. Typically, it is a psychotic spectrum disorder, schizophrenia most commonly, or schizoaffective disorder, schizophreniform disorder, or brief psychotic disorder. Those tend to be the primary causes of somebody experiencing psychosis. That being said, folks can also experience symptoms of psychosis related to an affective disorder, such as bipolar disorder or major depressive disorder. Some substances, PCP, hallucinogens, cannabis, can cause psychotic symptoms, and those tend to be more fleeting if the cause is in fact substance use. And then there are some rare but notable secondary medical causes, such as Parkinson's or epilepsy. So what would contribute to the development of psychosis? We think about kind of two things, generally speaking, vulnerability and stress in the interaction of those two things. So when we say vulnerability, we're talking about a genetic predisposition. So this may be a family member with schizophrenia or another psychotic spectrum disorder, for example. Perhaps a pre or perinatal complication or trauma that made the brain more vulnerable to developing something like schizophrenia. And then when we say stress, this can mean almost anything. We all experience stress a little bit differently and may find different things stressful. But some examples may be, a history of migration. So folks who have immigrated are at a higher risk of developing psychosis. A history of trauma or abuse in childhood. Those folks also have a higher risk of developing psychosis. Exposure to substances, especially folks who have been exposed to substances earlier on in life. Perhaps they started smoking weed at 12, 13 years old, and it's been a kind of multiple times a day thing for many, many years, right? Those folks might have a higher risk. Major life transitions and significant losses, those can all serve as potential stressors to trigger the onset of an episode in somebody who has an underlying vulnerability. So, in the school setting, how might psychosis affect students? There are a number of different ways, and this is not an all-inclusive list, but some common things that we at STEP have seen. Folks who experience hallucinations may be distracted during class. It might be really difficult for them to hear what the teacher's saying or concentrate on what's being taught. If they're experiencing paranoia, they may feel uncomfortable sitting in particular locations. Perhaps they don't want to be near the window. They may not want to be at the front of the classroom. They may prefer the back where they can sort of see everybody. Um, Cognitive symptoms. This one's frequently overlooked. So when we say cognitive symptoms, what we really are talking about here are disruptions to the way one typically is able to think. And this might look like trouble focusing, trouble remembering things, difficulty processing things at their usual processing speed, some impairments to their ability to encode and recall things that they're learning in class, maybe more difficulty than usual organizing information and tasks, or challenges really completing assignments in on time in ways that they previously used to be able to do. And then negative symptoms can make it very difficult for somebody to have both the motivation and energy for and interest in school, in participating in class, in interacting with other students. And this is really a separate issue from kind of volitional disengagement, right? Somebody who just, maybe they've never been particularly interested in school, or there might be other things going on at home that are making it difficult to come in, right? But folks who really truly are struggling because of psychosis to kind of engage in school in the way that they used to, for example. So, in the school environment, how might this look? Students with psychosis may seem distracted. They might exhibit difficulty concentrating. They may be responding to internal stimuli, as I spoke about a little bit earlier. Perhaps you see them kind of mumbling to themselves under their breath, or maybe they're kind of keeping to themselves and seem to be looking at something in a little bit of a strange way. They may seem suspicious of their peers or their teachers, on edge around other people. They might start really disengaging from their friends, from class, from extracurriculars. You may see a drop in grades in folks who, perhaps they used to be kind of, that A, B student, doing pretty well, generally turning things in on time, to suddenly they're getting D's, they're not completing their assignments, maybe they're not showing up at all, right? Or they're showing up late. Those can be some indicators. If you're seeing folks who um, are struggling with attending to their hygiene, their appearance, that this is not, I want to make a point that this is not sort of a poverty issue, right? But where this is a real change, perhaps somebody who used to, take real pride in their outfits, in their hair, in their makeup or shoes or nails or whatever it may be, and suddenly for, maybe a prolonged period of time, they're really struggling with those things. That can be an indicator. Um, Odd or unusual behavior. Again, that's a little bit vague. It's one of those we tend to know it when we see it kind of things, right? But if you see somebody who's really behaving in a way that seems generally strange, or not quite sensical given the context that the person is in the moment, that could potentially be an indicator. If somebody is speaking to you, students speaking to you, and they really are not making a whole lot of sense when they're speaking, perhaps you're having a lot of trouble following their train of thought. They're having difficulty kind of making their point, um, or having these ideas that are very disconnected. That may be a sign. Maybe they are even outwardly endorsing some strange or unusual ideas or beliefs to you that, kind of leave you scratching your head like, hmm, that's sort of something, I don't think most people would believe or agree with. That might be a little bit of a red flag there. And then somatic complaints. We see somatic complaints come up for folks, not infrequently, maybe feeling like there's something in their ear, in their stomach, if they're repeatedly, seeking sort of medical interventions for things, and, nothing's coming up on testing or on evaluation. That can be a sign. School nurses might be more likely to see some of that, right? If you have a student who's continuing to show up in your office complaining about, something bothering them physically, and tests have ruled everything out, that might be an indicator. I want to make a point that students who are experiencing psychosis are at, really a heightened risk for dropping out. And that's not a great outcome, right? We want people to be able to stay in school. We want people to be able to complete school successfully. And so we need to make sure that we're really kind of doing our due diligence and getting these folks the supports they might need, and especially getting them connected to treatment so they can continue with things that are important to them, like school. Myths abound about psychosis generally, and including students with psychosis. So, you know, some folks may think, well, there are no students at my school who experience psychosis. It is rare, but it's probably there, right? There are likely a couple of students or a handful of students at any given school who's experiencing psychosis, given the rates we know about it. Uh, Another myth that students with psychosis cannot remain in school due to impairment from symptoms on academic functioning. Students with psychosis cannot remain in school due to their risk to fellow students, or students with active symptoms of psychosis must take a leave of absence and cannot return to school until all symptoms have been resolved. Again, we really know that roughly 3 out of 100 people has a schizophrenia spectrum disorder, and the age of onset, is very much overlapping with high school, college age students. And so again, most schools are going to have at least a small handful of students who may be experiencing some psychosis. Students with psychosis can remain in school or return to school with adequate treatment, with adequate supports and accommodations where needed, even if they're having ongoing symptoms. This is obviously sort of individually dependent, right? Depending on the severity of the symptoms, depending on the student and their goals, depending on the accommodations that they do or do not have. But it is absolutely possible. And a note here too that the expectation of complete resolution of symptoms before somebody returns to school is not always necessarily achievable or feasible for folks, right? Even if somebody's getting the best treatment, they may still occasionally have some lingering symptoms. And so we don't necessarily want to use that as a benchmark for somebody returning to school. And then finally, we know that students with psychosis are not any more likely to be dangerous than the general population, especially when they're receiving treatment, right? So we want to be very careful about assigning any sort of stigma around violence or additional stigma around the likelihood of violence to folks and students who are experiencing psychosis. If anything, these folks are more likely to actually be on the receiving end of violent crime. Um, and finally, we know that, continuing to engage in meaningful activities, goals, roles like that of being a student in a school setting is a really, really important part of somebody's recovery, right? It helps them maintain ties to supportive friends, to supportive folks in the school setting, helps keep them engaged in sort of the community around them, gives them something that's meaningful to continue to work towards, right? That's really, really important for folks as they go through their recovery process. So, if I am a teacher, a coach, a school nurse, a school provider, a clinician in the community, how do I want to think about engaging with a student with psychosis? First and foremost, as many of you I'm sure already are doing, really important to create a trusting, trustworthy, safe relationship with the individual. Um, Identifying their shared goals. And for many people who are students, it's going to be, I want to stay in school. I want to graduate. I want to finish these classes. I want to go to college. I want to complete this semester. I want to study abroad next semester, finding those shared goals. And really, really being there to validate and normalize the underlying emotions and of what they're experiencing and the related concerns. Um, of course, we want to be careful not to collude with delusions, right? but we can always, I think, get on board with, if somebody's telling us, I am fully convinced that, my father is putting poison in my food, and we're doubtful about that. We don't want to get into a power struggle over it, right? And we don't want to say, yes, you're right, your dad's poisoning you. But, I think we can all agree that that would be a very terrifying thought or a very terrifying experience if we thought that that was truly happening to us. And we can always kind of get at that underlying feeling there. Really important to understand when you're working with somebody who's experiencing psychosis, especially if they're not already connected to treatment, particularly if they're not already connected to treatment, that this population is often treatment reluctant, not always, but often, and a big part of that is the stigma, right? And some of that also can be the symptoms of psychosis. It may be delusions, it may be fear about what treatment involves, right? There are many valid reasons for somebody with psychosis to be treatment reluctant, and so we just, we want to make sure that we've kind of got that context in mind when we're working with folks and trying to help connect them to care. Asking soft questions, being curious. It is such a relief for folks who are experiencing this just to have somebody that they feel like they can safely discuss what they're going through with, where they feel like they don't need to hide, where they feel like they're not being judged, where they're not going to be, you know, kind of kicked out of school or immediately shut down or doubted or talked down to in any way. Just being sort of a non-judgmental, gentle listening ear goes a long way. Again, we want to avoid power struggles, not debating delusions if they're bringing them up with us. You know, we'll tend to lose. It's very difficult to convince people out of beliefs. Again, we don't want to endorse things that we know to be delusions, right? We don't want to collude with that. But we also don't need to get into a space where we're sort of having this back and forth power struggle. Um, Also, just a sort of a side note to be careful about assuming that something somebody is telling you is delusional. They may tell you they're a musician or that they've developed some fashion products or that they've been harmed by someone, and those things happen to people, right? And people do, succeed in some of those goals, and so we don't want to assume that everything they're telling us is delusional, right? Um, being mindful of our tone of voice, our body language, our word choice, our pace and length of speaking. Those are all good things to keep in mind where we can. Um, Folks who are experiencing psychosis, particularly if they're having some active symptoms, they may already be on edge. They may already be kind of suspicious, worried about talking with us. They may be having some trouble keeping up, processing things at their usual processing speed, attending to what's being said. And they're often very wary of being categorized and treated as crazy or dangerous, right? The stigma absolutely exists, and folks are aware of that. They're aware that that stigma exists, and nobody wants that on them, so we need to just be really careful about language there. So most importantly, normalization and hope, letting people know that psychosis is a thing that people experience, right? They're not alone in this. Is it rare? Yes. But we know that somewhere between 1% and 3% of the population has a psychotic spectrum disorder, right? And that even more, maybe as much as 10 or 12% of individuals may experience some kind of subclinical, subthreshold clinical psychotic symptoms, right? Where maybe they're not at the threshold of being able to be diagnosed, but do experience some symptoms, right? We do not want folks to feel any othered than they already do by these symptoms. And similarly, offering them the hope that there's treatment available, there's treatment out there, and it works. That can be really, really reassuring for folks. And talking with them about what treatment looks like, right? Because a lot of people have, some misconceptions that it involves electroshock treatment, right? Or that I have to be locked up in an institution for the rest of my life, or that I'll have to take, a million medications for the rest of my life. And that is not what treatment usually entails for folks, right? Generally speaking, it's on an outpatient basis, right? So, for example, at STEP, we have folks typically coming in about once a week to meet with their therapist and meet with their psychiatrist as needed, and take a medication if it's indicated, and then also get supports for school and for work, and learning about the illness and ways that they can cope with it, right? It's often much less scary and intensive than people fear it's going to be. So, if somebody is experiencing early psychosis, what services are indicated? We use this term early intervention services, and we think about, it's exactly as it sounds, right? Early on in the course of psychosis, we want to intervene. We think about this in the field generally as being within the first 3 years after symptom onset. Ideally, it would be great to get somebody into care within the first 3 months, right? The sooner the better. And really, the goal of this is to reduce what's called the duration of untreated psychosis, or DUP. Um, Oftentimes, early intervention services looks like what's called coordinated specialty care, or CSC, which typically includes, as I mentioned earlier, kind of a menu of options of different treatment interventions to support the whole person, right? Medications and health promotion, individual therapy, maybe some group therapy, family support and psychoed, support for one's employment or educational goals. Maybe they need some case management support, peer support. And then ongoing, monitoring and evaluation of one's recovery process. So, why do we care about reducing DUP? As with many things, the sooner we address it, the better, right? Better clinical outcomes, less severe symptoms, less impairment and functioning from symptoms, fewer hospitalizations, better long-term trajectories. We know folks with shorter DUPs are able to maintain more engagement in school and work. They have a decreased risk of suicide, decreased risk of disability, uh, decreased economic cost to society. For me, the big one is better quality of life and decreased suffering, right? It is very, very impairing to one's life and lifestyle to be suffering from untreated symptoms of psychosis. So, what's the STEP Learning Collaborative? We are this Connecticut's statewide learning healthcare system for treating individuals between the ages of 16 and 35 who are experiencing recent onset schizophrenia spectrum disorders. We sometimes use the term FEP, which stands for first episode psychosis. That's a little bit of a misnomer, right? Because we don't always catch somebody right after their first episode, but we kind of use that to refer to folks who are early on in the course. And we involve a network of 20 clinical care sites all across the state in each of the 5 DMIS regions that provides care for young adults 16 to 35 with early psychosis who live in the state of Connecticut. We're supported and funded by Yale School of Medicine, DMIS, DCF, NIH, and our flagship clinic is here at CMHC, though, again, our clinical care sites are all around the state. So what are our goals here at the STEP Learning Collaborative? We really have a big focus on improving access to care, or shortening the DUP again, and improving outcomes. So we survey patients and their families and providers over time to see how folks are doing, and want to try to address any regional variation there and make sure that folks are getting good, high quality care. We focus on building workforce capacity as well. So you all are participating in that today by joining us, right? You are providers and educators and coaches and folks out in the community serving a professional role who may be interacting with students with psychosis. And getting some information about this is one way to help folks who are not connected to care and need some help getting connected to care. And then again, public education, similarly. So, all right, Josina, I've got a student I'm working with. I think they might have an emerging psychotic disorder. What do I do? So each of these little nodes here is one of our clinical care sites all across the state. So we really are all over the map. Call us. If you're concerned, just give us a call. Please do not feel like the onus is on you to tease out, is this psychosis? Is this bipolar disorder? Did it just start this year? Has it been going on for longer? We will do all of that. Give us a call, give us the information, um, and we'll sort out what may be going on. So we have this one central referral number. Anyone in the state can call. An individual can call about themselves. A family member can call. A provider, an educator can call, a coach, really anyone. We take referrals from everyone. And so we provide screening for psychosis and then rapid access to outpatient care if it is indeed early psychosis. We offer free monthly provider trainings. So for folks who have not participated in those before, I'll say a little bit more in a moment, but that's one of our offerings. Free provider consultation for any type of provider in the state of Connecticut, social workers, psychologists, psychiatrists, APRNs. We offer family and community workshops and resources. And then we have a whole host of virtual resources on our website as well. Kind of asynchronous learning modules, tip sheets, blog posts, all kinds of wonderful things for folks to get into. So if you call us, what's going to happen? Demas has kind of divided the state up into 5 regions. And we have what we call EDACs, early detection and assessment coordinators, who cover these regions of the state and take calls, depending upon where the individual is residing. And there are staff who do the screening and then the diagnostic eval and assessment to determine the presence of early psychosis in the individual being referred. So again, here's our number. We also have a handy online referral form if that feels easier and less cumbersome for folks. That's an option as well. And then one of our EDACs will give you a call back once that's been received. So let's say you give us a call, right? You call our referral line. We have some eligibility criteria, though really they are quite few. Does it seem to be like this has started within the last 3 years, as opposed to this is somebody who was diagnosed with schizophrenia, 8 or 10 years ago? Are they between the ages of 16 and 35 years old? Are they agreeable to participating in the program? And, a special note, we take folks regardless of insurance status. So private insurance, Husky, no insurance. There are no sort of exclusionary criteria based on somebody's insurance status. Anybody who we deem ineligible for whatever reason, we will also help direct them to more appropriate care. If there seems to be another kind of mental health condition going on. So the EDAC will, they'll go through their assessment, and then what they are going to do is, they'll make contact with the clinical site at the local LMHA for the where the individual lives, and they will provide them with all of the information that they've gathered through the screening and the evaluations. And a big part of what the EDACs do is really help smooth that pathway into care. Again, we know this population tends to be fairly treatment reluctant, that there might be a million and one reasons why anybody might fall through care, right? Maybe they miss an appointment and then they forget to reschedule, or they don't have transportation, or the appointment gets rescheduled, but they don't get the message. Maybe the individual starts to have some doubts about whether they want to go. The EDAC is really kind of the person there to grease the wheels and help make sure that the individual gets to their initial treatment appointments and gets there in a timely manner, right? So we have a goal of making sure that folks, once they've been referred and identified and confirmed early psychosis, that they get their first clinical appointment within about a week. And then the EDAC continues to meet in an ongoing way with the new providers at the LMHA to make sure that we're troubleshooting any issues that might come up. Um, helping make sure that they have the supports and the resources that they need to continue to work with the individual. And again, I think I mentioned that we do, monitoring for outcomes, right? So every 3 months, folks will get surveys to see how they're doing and see whether there's anything we can do to better support their engagement, or better support their treatment or their symptoms and outcomes. So some resources for you all. Again, we have our free virtual trainings for providers. Typically, it's the first Thursday of the month, 12 p.m. to 1 p.m. through Zoom. You can register for that on our website. We have a free provider consultation line. Again, any provider in the state who has a question or an issue related to somebody they're working with who may be experiencing early psychosis, you can send an online inquiry form. It's a very brief form and schedule right away a consultation with one of us here at STEP. We do consultations on therapy, on medications, on family issues. Really runs the gamut there. And then again, we've got, various asynchronous learning modules, tip sheets. All of our previous provider trainings have been recorded and are available on our YouTube page. We have resources for family members and community members as well. So we've offered virtual workshops for family members. We're revamping the schedule a little bit, so stay tuned. I believe that we have some things recorded as well, which would also be available on our YouTube page, and a number of resources also on our website for family to dig through. How do I talk to my young person about their symptoms? How do I encourage them to get into treatment? How do I talk to them about weed? What does psychosis mean? What does this look like for their future? We have a number of resources on our website addressing those things. Again, visit us on YouTube, Step Learning Collaborative, if you want to check out any of our past trainings. So why should you call us and refer somebody if you're concerned? Again, we provide rapid access to a network of outpatient care, regardless of insurance. Our goal really is to smooth the pathway to care. So we all, as professionals, as providers, as family members, as neighbors, as citizens of Connecticut, whether we know it or not, are part of this network. That really interfaces with folks who have psychosis, and so we each may find ourselves kind of in the position of potentially smoothing that pathway and getting somebody connected to care and intervening. Again, through the learning collaborative, an individual who's referred will get individualized support for engaging into care. Will monitor outcomes over time to really try to improve things over time. Um, Trainings, consultations for providers, the education and workshops for families, all the virtual resources. And again, this really is a statewide system, right? We are trying to we at STEP have been here in New Haven for a number of years, almost 20 years, I think. And we really want to try to make sure that the whole state is covered, right? That folks who live out in Torrington, in Tolland, in Darien, in Groton, that folks have coverage all over the state with good, high quality care. So one last thing, again, call us, even if you're not sure, or fill out our online referral form. The onus is not on you to tease it out, right? That's our job. Even if you just want to run something by us, just give us a call.